They're the ones who raise the bar. The ones dedicated to providing care in the most demanding of circumstances. The ones that understand the healing benefits of kindness and compassion. They're the people of Sarah Bush Lincoln, and they set the bar high. Sarah Bush Lincoln, trusted, compassionate care right here close to home.
For over 50 years, Horizon Health has been keeping you and your family healthy. And although some things have changed, Horizon Health's commitment to meet the ever-changing needs of our community has remained the same. Horizon Health, 50 years strong.
Carl is redefining healthcare around you, innovating new solutions and offering all levels of care when and where you need it. Investing in technology and research to optimize healthcare, Carl, with Health Alliance, is always at the forefront to help you thrive.
Thank you so much for joining us for this episode of Being Well. I'm your host, Lacey Spence, and today we have a guest who's here all the way from the booming metropolis of Mattoon. We have Dr. Dean Katsamakis, and you are here from the cardiology department?
Correct.
Can you talk a little bit about how you got into the field you're in?
Sure. Well, I have a tie to this area. I went to undergrad at SIU, and I trained in aviation flight. So I was a commercial pilot before I went to medical school.
That's cool.
So I used to fly around this area. I've flown into the Mattoon airport back when I was training. And so I knew the area very well. Subsequently, I came down here approximately 11, 12 years ago, and I was the cardiologist for Sarah Bush Lincoln Hospital at a time of transition between their programs. And so I spent several years down here and really enjoyed my time. So that's how I got here. How I became a cardiologist was, I think, having trained as a pilot and having sort of that aptitude toward quick thinking on my feet is why I also became a physician and an interventional cardiologist, which is a person who places stents in various arteries of the body and veins. And it takes a certain person that is willing to persevere, so to speak, in fixing these things. And it takes someone who is willing to sometimes go into some areas that perhaps others wouldn't. And so I think that and my flight training helped me.
I'm out here, a cardiologist and a pilot. What am I doing here? Well, today we're talking about COVID-19 and heart issues. We know that COVID has been rampant the last year. So we are currently taping this in May of 2021. And so just for our viewers at home, if things happen to change by then, that's why. But as we're taping it now, here's the info that is fresh from the doctor. So right now we're wanting to talk about, is COVID-19, is it associated with heart complications?
It can be. COVID, generally speaking, what we know about it now after all this time is that it is usually a viral illness that causes a fever, sore throat, perhaps some GI symptoms, muscle aches, etc. That's the most common form of COVID infections, but there are times when it becomes more serious. The way that works is it causes an inflammation in the body. So it can cause an inflammation in the lungs, and that lung inflammation can lead to something called pneumonia. And pneumonia, of course, can lead to cardiac implications. It can cause a reduced oxygen carrying capacity to the blood, and that can put strain on your heart. It can also cause inflammation in the vascular system, which can lead to low blood pressure or hypotension. So it can cause COVID-related heart issues. Other COVID-related heart issues that we've seen are blood clots, which can form inside the heart or in the lungs, which is pretty serious. We've seen people having mild or even large heart attacks with COVID, arrhythmias, which are abnormal heart rhythms that can cause the heart to beat out of whack, so to speak. So there's a multitude of complications, although the majority of people with COVID, even if they have heart issues, will be safe.
That was kind of my next question. If I'm somebody who already has an existing heart condition, does COVID-19 affect me differently?
It can, but usually there are other comorbid medical conditions, which means other things that people suffer from, other medical illnesses that they suffer from that also will prompt that. Generally speaking, the older you are, the more serious COVID can be. But yes, COVID can affect people with heart disease a little more significantly, but not always, not always.
And I feel like people maybe have heard in the news a little bit about kind of like a long hauler's disease or things like that. What do kind of the lasting effects of COVID-19 look like?
You know, we've seen a lot of that because as we've learned more about COVID, and we at Sarah Bush have taken care of quite a few people with COVID, we've really learned about what the effects are long term. And what we've seen is after COVID infections, we've seen people develop what's called a cardiomyopathy, or an enlargement of their heart. Which is unbeknownst to them a lot of times, because in the midst of the infection, they're not feeling well. They're short of breath, they have a fever, they're coughing, etc. It's only after that period of time that they think they should be getting better that they then say, well, I'm not feeling better yet. Why is that? I should be better. I'm 1 week, 6 weeks, 3 months past the infection, and they're still complaining of symptoms. It's at that time we've seen people with what's called a cardiomyopathy, enlargement of the heart. We've seen people also have prolonged lung infections where they've had diffuse and prolonged inflammation of the lungs. So it's not necessarily a pneumonia, it's more of a inflammation of the airways which persists. Quite frankly, we've seen this for years with many different viruses. So it's not just COVID, but it's become more prevalent or more prominent to all of us now that COVID was such a big deal. But it is happening. The good news is that majority of those people over time will get better. With regards to the heart, it's still unknown. I mean, we're seeing people with cardiomyopathies or enlargements of the heart. We're treating them, we're putting them on the right medications, and then we're watching them. And the way we do that is with a clinical exam, an EKG, and sometimes an echocardiogram, which is an ultrasound of the heart, to evaluate the squeeze and function of the heart. And I will tell you sort of anecdotally from my practice, we've seen that the majority of those patients over time are getting their heart function back as well.
That's a relief. So more or less, it just sounds a little bit scarier just because it's been the new information that keeps coming out.
Yeah, I mean, it is. It's scary for a patient who suffered from COVID, because just when they think, boy, I've gotten past it and I'm ready to get better and I should be feeling better, and they're not, that's concerning. It's concerning for anybody, because you think, boy, you know, I made it through it and now I should feel better, and then you don't. But I think, you know, looking at the glass half full perspective is that over time, these people will get better generally.
And the folks who are finding that they have the enlarged heart, how are they, at least in your experience, how are they discovering that they have this? Is it more of an ER type of thing or just a regular doctor
Well,
visit?
a lot. So, for example, if a student athlete gets COVID, what we usually do with these people is we have a screening exam after they've recovered from COVID, and that usually includes perhaps an EKG. And based on that EKG, if we see something that alarms us or concerns us toward something more serious with the heart, then that prompts a more thorough exam and perhaps an echocardiogram. So generally, the way that we confirm, let's say, a post-COVID cardiomyopathy and enlargement of the heart is with an echocardiogram of the heart. That's the ultrasound that shows us how the squeeze and function of your heart is doing. It evaluates all the valves of the heart, and that's a pretty thorough investigation. And once we do that, we're able to tailor the treatment toward what their condition is.
I don't know if there's folks at home like me, but I've always wondered, what's the difference between the EKG and the ECG?
Same thing, electrocardiogram. So it's actually ECG. So, yeah.
Okay, good to know.
Yeah.
So you are an interventional cardiologist.
Correct.
What does that mean? What do you do?
So there's different aspects of cardiology. Through the years, we've sort of subspecialized within the specialty of cardiology. Years ago, you were a cardiologist and you kind of did everything. You were a jack of all trades. But as the technology has become so vast and it's so rapidly changing, the field kind of determined that it was best that we had people that specialized in certain areas. So there's electricians and then there's plumbers. A plumber is an interventional cardiologist. We go in and we get rid of blockages or fix blockages in the arteries of the heart. There's electricians who work on the electrical portion of the heart, and then there's general cardiologists who are excellent at treating illnesses based on diagnoses and doing imaging. So an interventional cardiologist is basically someone who fixes blockages in the arterial system and also works on the veins throughout the body, basically from the neck all the way down to the toes.
That's probably the easiest way I've ever heard it explained. That makes so much sense.
Yeah.
And I'm sorry if I missed it. Were you always specialized, or did you have to start as a general?
So the way we train is we are all board certified internists before we go on to do a fellowship. So I did my training at Rush University in Chicago, and then I was a chief fellow there, and then I did a cardiology fellowship, which was 4 years, I think, of general cardiology, followed by an interventional cardiology fellowship, which was a specialized 2 years where I learned how to place stents in the body.
Gotcha. So one of the other things that we were wanting to talk about today, besides just COVID and heart health, would be peripheral artery disease, PAD. Can you talk about that a little bit?
Sure. PAD is a diagnosis which I think people have heard about sort of peripherally, but don't necessarily know a lot about it. PAD is a diagnosis of blockages in the legs, in the neck, in the abdomen. So it's anything outside of the cardiovascular system. And it, because if you think about the heart, the arteries in the body are all the same. They're all affected by cholesterol the same. So if you smoke, if you don't exercise, if you eat improperly, as you get older, atherosclerosis of the arteries occurs. And that atherosclerosis or hardening leads to blockages. And so these blockages that occur in the neck and in the abdomen and in the legs are what's called PAD, or peripheral arterial disease. The way that it usually presents itself, if we're talking about the legs specifically, is pain. So it's almost like pain in the heart. Well, people get pain in their legs. When they walk, they'll say, I get this cramping in my legs, particularly in the thighs or in the calves, that gets better when they stop walking. And that's usually a good sign that they have a blockage in the arteries of their legs.
And so what does that blocked artery feel like as opposed to just a regular exercise kind of pain?
Yeah, it's more of a cramping pain, kind of a tightness. And again, it occurs primarily in the lower leg. So usually below the knee particularly is where people will feel it. And it's sometimes difficult to tease out because one of the great mimickers of PAD is low back pain. So people often say, I get this pain and I think it might just be my back. And we say, well, okay, tell us about it. And what they'll say is, if it's the legs, it hurts when I walk, it gets better when I stop walking. With people with back issues, especially lumbar or lower back issues, especially spinal stenosis, they'll say, it hurts when I walk, but when I bend forward, it actually feels better. And the reason is because they're releasing those nerves from being compressed by the spine. And so they can walk, for example, bent over with a shopping cart just fine. It's only when they stand straight that they feel the discomfort. With PAD patients, doesn't matter what they do, they'll have pain. So if they can walk bent over, walk standing straight, they'll feel that discomfort in their legs.
Is there a certain demographic that you typically see this with?
Sure. Yeah, I'd say obviously age always predisposes to atherosclerosis of the artery, so age is certainly one. But the biggest one is unfortunately smokers, and the next biggest one is patients with diabetes. So those are the two biggest ones. Tobacco use and diabetics are at very high risk for developing PAD. And after that risk, they're unfortunately at very high risk of developing wounds in their feet and legs, which become non-healing, which then leads to amputations or infections. And so you hear about diabetics very frequently who have lost a toe or a foot or even more. And it's because they generally have bad peripheral arterial disease, which has resulted in a lack of blood flow and therefore death to the tissues. And so our job is to diagnose this before it happens and to treat it. The best way to treat it, of course, is to attack the disease itself. So making sure your diabetes is well controlled, making sure you're not smoking, making sure the cholesterol is well controlled, exercise. But if we can't do that, then it's time to treat it with interventional procedures.
And so you don't have to be diabetic to get this?
No, generally, you don't have to, but I will say that the majority of people that have PAD are either smokers, diabetic, or have a significant age. That's usually the case. Nothing is 100%, but invariably that's the cause.
And when you talk about death to the tissue, if you're able to or unable to help with that, is this something that can be fatal?
Well, yes, it can, because if you think about the downstream effects, right, if you have a serious blockage that is unfixed, the tissue begins to suffer and eventually die. But while it's doing that, you can develop gangrene. We've all heard of gangrene before. We don't really know what it is, right, if you're not a physician or suffer from it. But gangrene is basically death to the tissue. So when those tissues begin to die, they become infected. And so that infection then can get into the bloodstream and, of course, cause serious problems.
And so what does the treatment for PAD look like?
Well, the cornerstone of treatment is, again, to stop smoking, control diabetes, make sure blood pressure and cholesterol are well controlled, and exercise. It turns out that daily exercise, approximately 30 minutes daily, for people with PAD is the best treatment. It sounds sort of counterintuitive, or, oh yeah, of course I'm gonna exercise, but it hurts to exercise. Yes, but that's the point. You need to get the blood flowing. And it actually, when you exercise, it actually promotes new blood vessels from forming around blockages. That's called collateral blood vessels. So it's a tremendous benefit to exercise. If that doesn't work, then the next step is to do a stent or a balloon angioplasty of one of the arteries to try to improve that blood flow.
And have you noticed a big change in the treatment options just in your time in the medical field for this?
Yeah, definitely. I mean, when we first started, I would say, first of all, I mean, the treatment, the aggressive treatment of peripheral arterial disease outside of just medications and diet and lifestyle and treatment of these underlying medical issues was very limited. It wasn't until we started placing stents in the heart that we really started doing more work on the peripheral arteries. So we first started out by putting stents almost in everybody, in almost all the arteries. And although that was good and it provided great initial blood flow, what we found was that the stents were starting to narrow pretty quickly, and they were having problems in the legs, such as cracking or fractures of the stent. So then new techniques have been developed. Some of those are called atherectomy, which is a device that goes in and basically shaves away some of the blockage or the atherosclerosis. It's a tremendous device that allows us to open the artery with much less trauma. And then now the most new or current iteration of treatments are called drug-coated balloons. So everybody's familiar with drug-eluting stents in the heart. These are stents that emit a drug to prevent re-narrowing of the stent. Well, instead of having to put a stent in the legs, now we can just put a balloon in there that emits this drug or elutes this drug and prevents re-narrowing of the artery. And it leaves nothing behind, which is really nice, because there's a balloon, we inflate the balloon, the drug stays behind on the walls of the artery, the balloon is deflated and taken out of the body, and nothing is left inside.
I assume this is very minute equipment that you're working
It's
with?
very minute. We're talking about balloons that are, I would say, anywhere between 40 to 100 millimeters in length and 4 to 6 millimeters in diameter. Millimeters, so that's really small. Yeah.
And I know today we've kind of zeroed in on COVID and PAD. Is PAD the largest, I guess, condition that you see, or what's most commonly walking through your door?
No, I mean, I think with all cardiologists, particularly here at Sarah Bush, we, I think, primarily see coronary artery disease. So atherosclerosis of the heart arteries is probably one of our largest diagnoses. Similar to PAD, the risks are, of course, age, diabetes, smoking, high cholesterol. Family history also plays into atherosclerosis of the heart arteries. That's the largest, I think, diagnosis, coupled with arrhythmias such as atrial fibrillation, which is an arrhythmia that causes the heart to beat fast and irregularly. Those are the big diagnoses that we see. Fortunately, here at Sarah Bush, we're able to treat all these very well, including coronary disease. So just like in the legs, if you have a blockage in the arteries of your heart, our first goal is to treat it with medications and diet, exercise, lifestyle modifications. But if we can't, then we're able to put stents in there too.
And if I'm somebody who is wanting to have my heart and things checked out, is that something that my primary care doctor can handle, or do I need a referral for you?
Generally speaking, you can do most heart checks through your primary care physician. The one check that I would say, well, there's a couple. First, always checking your cholesterol is important. When you reach, above your teens, you should have a cholesterol checked, and obviously follow that. Making sure your blood pressure is well controlled, checking to make sure you're not diabetic. Those are, I think, the first steps in screening for any heart issues. One of the tests that we frequently recommend that Sarah Bush offers is a heart screen, and that is a test that we do that checks the arteries of the neck, the arteries of the abdomen, and of the periphery, so the peripheral arterial disease, so it screens those. And it also does a non-contrast CT of the heart, which is called a heart CT. That is a tremendous test because that tells us if you have calcification in the arteries of your heart. If you remember before, I said that the arteries of the heart are the same as the arteries in your neck, in your abdomen, and in your legs. So we can use that data and sort of translate it to anything else in your body. When we do this CT scan of the heart, what we're looking for is calcification, which is atherosclerosis, hardening of the arteries. We're able to give you a score and base that score on your age, your gender, your ethnicity, and race, and we're able to tell you where you rank and where you think you should rank. So a score of 0 is, of course, perfect. You have 0 calcium in your arteries, you have very low risk. If you have a score, let's say above 400, your score is very high. That puts you at high risk. And we can use this then to say your 10-year risk of a heart attack or a stroke is also very high. And then that helps us tailor treatments. So getting back to your question, can you get screened? Absolutely. And that one you can do without a referral from either a primary or a cardiologist.
Is that like a long process to get the test done?
No. The test, I don't know the specific time, but I can't imagine it takes more than 30 to 40 minutes.
So after somebody ends up in your office and under your care, what's the most common question that you get from them?
How can I prevent myself from having a heart attack? It's true. And I mean, everybody thinks that.
Yeah.
I mean, who wouldn't think, especially if you have a family history or, I mean, how many people know that anecdotal story of a person that they knew that was in great health, quote unquote, and then they suffered a heart attack. And everybody says, well, I knew this guy and he, was out working and then he had a heart attack. And it's like, how does that happen? And how do I prevent that from happening to me? That's the number one question. And it really goes back to that long answer that I just gave, which is prevention. So diet, lifestyle, exercise, but also making sure that you know what your risk is. That is I can't stress it enough. Everybody says, get me a stress test. I want to know if I'm going to have a heart attack. That's not where you should be focusing. You should be focusing on what your risk is. And where your risk is what is your cholesterol, what is your blood sugars, and what is your heart score. That's really where you will determine what your risk is, and then we can therefore help prevent you from having a heart attack.
What's kind of a prognosis for somebody who is being put on the blood pressure medicine and the cholesterol medicine? Is there still hope for them to be able to kind of reverse that through a healthy lifestyle, or once you're on it, are you on it for life?
Nothing's ever for life, especially in my practice. I always tell people, we're putting you on these until you can prove that you don't need to be on them, right? I mean, really the body has a miraculous way of healing itself if we allow it to. But if we negate whatever good we have through poor diet, lack of exercise, etc. We can't change age. Of course, age is age, but the other things we can change. We can not smoke, we can not be diabetic, and we can lose weight and eat properly. And if we do those things, medications are just helping you to get to the point where your body can already get to on its own. Sometimes people just won't do it, and that's okay. We'll help them along. But there are people that are very motivated, and when we give them these ideas and these options of how to get healthy, they take it and they find that it works, and they can come off blood pressure and diabetes and cholesterol medication sometimes. Obviously, everything is, there's always, person to person,
right.
There's variability, but generally speaking, there is a great ability of the body to heal itself.
And then as we're wrapping up, are there any other natural supplements that people can take besides just the prescribed medicine that can help with lowering cholesterol or things of that nature?
There are. Unfortunately, as a physician, it's hard for me to recommend natural supplements because none of them are generally FDA approved or studied in randomized controlled trials. So we try to shy away from necessarily saying take this or take that. But there are supplements that people do take that tend to help. But ultimately, lowering cholesterol is best done through a proper diet.
And that was actually my next question. Which is the best type of diet? Because I know there are, it feels like hundreds out there to choose from.
There are. It's, that's maybe a contentious point amongst physicians and nurses and dietitians in the healthcare industry in general. But I will tell you that I think you could never go wrong by following sort of a Mediterranean diet, so a low fat, low saturated fat or animal fat, low cholesterol diet. It's always good to try to avoid carbs, which is very hard to avoid because carbs are almost ubiquitous to our diets, but all breads, all rice, all pastas, all potatoes, all sugars, lots of sweet fruits. This is starting to not sound fun. Alcohol. It's all these things are carbs, and carbs, just like fat and cholesterol, they raise your cholesterol levels. They lead to obesity, which leads to diabetes, which leads to hypertension. So it's a continuum.
Does that also mean a lot of colors on your plate, a lot of the fruits and vegetables type of thing?
You can't go wrong with lean proteins. So the white chicken, fish, white porks, red meat in moderation, of course, and dark green vegetables are fantastic.
Before we wrap, is there anything else that you'd like to tell the viewers at home?
I just think that I want to tell people what a honor it's been to be back in the Sarah Bush community and how much I enjoy being here, and it feels like home.
Excellent. Well, we are so glad that you came in today.
Thanks.
And we hope that you join us for our next episode of Being Well.
Carl is redefining healthcare around you, innovating new solutions and offering all levels of care when and where you need it. Investing in technology and research to optimize healthcare, Carl, with Health Alliance, is always at the forefront to help you thrive.
For over 50 years, Horizon Health has been keeping you and your family healthy. And although some things have changed, Horizon Health's commitment to meet the ever-changing needs of our community has remained the same. Horizon Health, 50 years strong.
They're the ones who raise the bar. The ones dedicated to providing care in the most demanding of circumstances. The ones that understand the healing benefits of kindness and compassion. They're the people of Sarah Bush Lincoln, and they set the bar high. Sarah Bush Lincoln, trusted, compassionate care right here close to home.